the great work we're doing in Nova Scotia. So you see in front of you an overview. Just briefly, I'll be talking about CASP and suicide prevention in Nova Scotia, and getting into what community suicide prevention means or is. Using the interpersonal theory of suicide, we'll talk about that, and what do we know works sort of from a higher level from all the collection of research from around the world. We'll get into the CASP coalition model and explain how that works, and I'm going to get into, again, a little deeper on the community side, the crisis of resiliency in Canada and the West, and of course we'll close by talking a bit about what we're doing about it. Next slide, please. So, first of all, CASP, Communities Addressing Suicide Together. Suicide's been addressed in Nova Scotia actually since 2003 formally. There was a large symposium, and out of that came a number of working groups who eventually formed the Nova Scotia Framework to Address Suicide in 2006. There was a lot of research and focus groups and work gone into that. And you could almost look at the framework like a national framework. If you take the time to look at the links that can be found online or through our website to the framework, it does not look unlike other, national strategies. But at that time, we performed provincial strategy. Strategy came with 6 key objectives: leadership, infrastructure, and partnerships, awareness and understanding, prevention, intervention, postvention, or bereavement support to those who aren't familiar with the term, and knowledge development and transfer. So, and then 2 entities came out of that to sort of implement those 6 key objectives. The Provincial Steering Committee, which is a cross-sectorial committee consisting of members from at-risk groups, as well as people involved in more of the formal mental health system, as well as others who have suicide prevention on their portfolio, like Injury Free Nova Scotia, for example. And it's meant to be a cross-sectorial approach to looking at suicide. And then CASP was formed, my organization, and I'm quite proud of, in partnership with the Canadian Mental Health Association of Nova Scotia. And CASP is not unlike a lot of localized community suicide prevention groups where we offer, we address those key objectives that I mentioned, and we do that through, offering different training programs, advocating for change in our communities. We offer some of the common ones that you might be familiar with, like Safe Talk and Assist, as well as reaching out from the Crisis Center in British Columbia. And we disseminate information, distribute and develop various resources to meet the needs of Nova Scotians and really all Canadians. Basically what happened in 2012, the mental health strategy came out, as Meg was just referring to, and also a mental health strategy for Nova Scotia was launched. At that time, it was decided to sort of wait and see what direction these strategies would point us in our work in Nova Scotia communities. And the Nova Scotia mental health strategy really just endorsed us continuing as we were. So we decided it was a good time to renew the steering committee, which we did. We invited the old members. Again, people change goals, people change mandates, and then we asked them to recommend, who was missing. We had a number of facilitated sessions, and out of that has come some new suicide prevention research, which I'll talk about in a while. And as a group, we came together that our top goal for addressing suicide is now resiliency. a term that wasn't maybe talked about a lot in 2006 or then, but as a collective, cross-sectorial collective, we decided that resiliency was really our what we're looking for. So that made a change in a number of directions, which I'll get into later. Next slide, please. So before we talk too much about what we do with communities, I think it's important that we sort of come to a consensus about what community suicide prevention is. Excuse me, and that's not an easy task. That might seem, some might assume that, oh, well, every group across the country, they're all on the same page, going for the same thing, and that's true. It isn't true. We have to be honest here that there's different types of suicide prevention groups. There's those that exist to memorialize and make a difference for loved ones that have been lost by family members. There's those that are more sponsored by community and are more tasked with be cautious around certain kinds of messaging. These are some of the real issues. Amongst those that have lost someone to suicide, with the suicide attempt survivors I've worked with, they say, we're the survivors of suicide, not those that have lost people to suicide. And we're getting left out of the conversation. So some, I don't know if they're listening, probably not, but some would say we shouldn't talk publicly about suicide at all, that it's dangerous, and don't talk about suicide publicly. And others would say suicide conversations should be a common conversation around the dinner table. Never sat around the dinner table together anymore, but that they should be as common as that. So, first of all, know empirically that suicide is a community public health issue. But it's also involves an individual's clinical mental health needs. It's not one or the other. It's both. And yet we to have a bit of a divide in that arena as well. And one thing I've noticed, and I'm going to get up on a soapbox for a moment. One thing I've noticed is that when it comes to funding, when it comes to people donating to and suicide, those donations tend to go towards the clinical formal system, and whereas community groups tend to spend a lot of time just scrambling to stay together, pull dollars together, bowl-a-thons and things like that. Whereas banks will donate to a hospital to address suicide, and I think it's really important that we view both equally, at least the same. Because we have lots of evidence. Now I'm going to ask Meg to be a little creative here, and if this doesn't work out, then we'll just include the links at the end. But thing is the social determinants of health. If you've heard that term, it's a basic public health term. And if you just type in SDOH, like Meg brilliantly just did for me, or social determinants of health, you'll see that there's numerous diagrams, that it's not a new topic. It's one that's taught in universities to health promotion students. It's well established that these different determinants, things like access to transportation, access to housing, access to many other things that, frankly, the Mental Health Commission is addressing, those all impact suicide, and they all can, if we understand their impact, we can also reduce suicide. For a Canadian example, you could just look at the work Dennis Raphael, the CanadianFacts.org. We often include these guidelines in our toolkits for our coalitions, which I'll talk about later. The listserv that sends you thousands of emails a day, so you decide if you want or not. There's facts that we know about the impact of public health, and suicide is amongst those. And Thanks for your seamless transition there. So it's a public health issue. It is impacted by by an individual's clinical mental health needs, but it's first and foremost, I would say, a community issue. And if you look at this definition, it's not written as a definition, but it's a quote that you can find on the website of the Canadian Association for Suicide Prevention. Suicideprevention.ca is their website. Our website. I'm the proud vice president of this organization, and pleased to say we have a new, beautiful website coming shortly. But I would look at this quote as a definition, and I'm going to read it to you as a definition, if I may. So community suicide prevention is recognition that suicide is most often the result of pain, hopelessness, disconnection, and despair. Community suicide prevention rises that suicide is almost always preventable through caring, compassion, commitment, and community. And I'd say that's a guiding principle for many of us who work in this area. And I'd say in a nutshell, if we had to boil it down, very hard thing to boil down, but we could probably mostly all agree that this is what community suicide prevention is about. Next slide, Meg. So, before we talk more about CASP and our model, again, I want to address again one of those schisms where, like in any community organization, I used to encounter this in autism all the time. There's a lot of programs. There's a lot of industry. There's a lot of belief that informs what people do that may not be based in evidence. So, record, if you look at the large meta-analysis studies that pull together all the research and look at what has really had an impact that we know had an impact, most would agree. I took this list from a big European Union review last year, but most different lists would agree that these are recognized things globally that make a difference in preventing suicide in the community. So I just want to touch on them, and we can discuss them at the end if you'd like. Safe messaging, and my heavens, we've known of safe messaging for over 200 years. It used to be called the Werther effect. That was because of a book called The Sorrows of Young Werther, written by Goethe, and it was the first time people noticed copycat suicide, that people were emulating the character in this book, and they were dying by suicide. And since then, we've been researching it, and we've been focusing largely on the mainstream media and newspapers, and we found just a wealth of evidence that unsafe messaging about suicide can actually make matters worse. So again, there is one of the conundrums, do we talk about suicide as often as we can, or do we carefully and selectively talk about suicide, recognizing that our audiences might be vulnerable? There's been a back and forth between, media outlets and different groups that are involved in community suicide prevention. But really, the challenge that's facing both is the internet, and that's a brand new platform. It's not the mainstream media anymore. It's also citizen media and alternative media. When it's viral on the internet, it's sort of like bets are off for the mainstream media, and they can report on the viral story without directly reporting on the side. I have the easy answers for this. New Zealand, in their strategy, they've banned public reporting of suicide outright, which is interesting. That's being challenged right now, but just to show that it's in at different levels in different countries and places. That safe messaging, we know, has a negative impact and if it's not done properly. So I'll leave that there for now. The other thing is means restrictions. So again, everyone should know that the RCMP will come to your house and remove firearms if you're worried about a loved one. Firearms need to be kept, locked and safe and away, especially if there's someone who's vulnerable or possibly vulnerable around. Old prescription medication can be returned to pharmacies. Those are actions everyone can take to ensure there's no unsafe levels of medication around the house. Countries, just because of the nature of suicide, they're more focused on locking pesticides and things like that. But whatever the case, restricting means we know worse. In Nova Scotia, an example of work CASP has done was to work with Halifax Dartmouth Bridge Commission to erect bridge barriers so that people would no longer be able to jump off the bridge. And involved also working with the Bridge Commission to help them better understand suicide and react to suicide. And it's an effective tool. It works. When I was growing up, that bridge was notorious. It's not notorious anymore. Alcohol policy, another one. Talking to our Nova medical examiner, he said that over 70% at least of people that that encounters after they've died by suicide had alcohol in their system, and that alcohol, we know, is a depressant. We know alcohol is actively used to treat anxiety, and we know that alcohol policy makes a difference in preventing suicide. So enacting, awareness around suicide and alcohol, I'm just speculating here, I would see as an important action that we don't often see taken. We can speculate on that, but alcohol is, and understanding the link between alcohol and suicide is important, and that we don't ignore it. Then universal approaches, and I put a little asterisk there because I will be talking about that more in the context of the CASP coalition in a little while. It's important to note that many of these large analyses do endorse universal approaches. They just don't really say what those are, and therein lies the conundrum for many of us in figuring out, the best approach. And CASP has come up with a model that we think works. The World Health Organization has informally endorsed our model at a prevention conference a couple of years ago, and we know it is having some positive effect. But on to that later, he says, after he goes on about. First, I want to talk about some of the other sort of evidence for community suicide prevention. There's two sort of famous researchers, Durkheim and Thomas Joyner. I'm just going to touch on Durkheim's work for a moment, and then I'm going to talk a little bit more about Thomas Joyner's work, which really built on Durkheim's work, right? And as a clinician, I'm not I'm not someone who's an expert in research or anything, but I do think it's important to know the research. So examples. First of all, Durkheim's enemy theory of suicide. Older, it's about over 100 years old, I believe. And he started by noticing community suicide by looking at Protestants and Catholics and noticing a difference between suicide rates and that they were lower amongst Catholics. And he started studying suicide from sort of a community angle. Nobody's perfect. His work and certainly science at the time wasn't perfect, but it's been criticized for being speculative, and it's been criticized for a number of reasons for being too correlative. If you know what I mean, that's just because I wear a hat and it doesn't rain doesn't mean wearing the hat means it rain. He made too many connections that maybe weren't empirically proven. But he did notice some important things that still inform our knowledge of suicide today. Rates being higher than amongst men than women. He noticed. He noticed that suicide rates are higher in times of peace than in times of war, and that tells us something. And anyway, I'll leave it there just because Durkheim's work was important, although flawed. It did lead to Thomas Joyner's work on the interpersonal suicide behavior. Next slide, please. Okay, so I kind of have a crush, I guess you could say, his work. And the reason this developed is, again, we do community suicide prevention, and when I look at what's commonly out there, one thing is there's a lot of mnemonics. There's the path warm, we've heard, I think, algae is the one from the mental health first aid. There's lots of different lists of risk factors. There's lists of warning signs. There's lists of protective factors. And yet, I'm not sure how well of a job we're doing explaining or helping people understand suicide, helping themselves understand suicide by using all these lists. So in my own digging around, I came across this webinar off by Thomas Joyner, and this diagram here, I'm going to explain it a bit, I think can help us make sense of community suicide better than a lot of other work out there. And it's important to point out this is empirical knowledge, Durkheim, noticed after a coup d'etat by Napoleon, rates changed. Well, Joyner's team has gone a lot more deeply, and they've been able to use, statistics to show the impact. The fact that when there's a national crisis, suicide rates go down. That's from after 9/11, suicide rates went down on 9/11. After a team wins, after the Habs win, or whoever, when we know suicide rates go down, and they've been able to prove that. So I encourage you to go and take a look at some of work. But so just quickly looking at the slide, and belongingness and perceived burdenness and a capability of suicide. 3 circles. And think of some of the common risk factors, some of the at-risk groups, some of the things going on in our society. They know because they're in the media a lot or for whatever reason. So let's take cyberbullying. That's a new thing that people are noticing has an impact on suicide. What happens to someone who's bullied? Their sense of belongingness is taken away. They're told they don't belong. They can perceive themselves as a burden. Maybe that's a side we need to think about more. That when they go to guidance, let's say they try to address the bullying and they go to the guidance counselor, or they have to move schools to get away from bullying, and it follows them through cyberbullying. They can start to see themselves as a burden, that they're a burden on their teachers, they're a burden on their other friends that aren't being bullied. And then let me take another example, just using the 2 big circles for now. Let's take high-risk group, men between ages of 50 and 54. Okay, what's happening to men during that time? They've grown up, divorce be a factor, or a change in the relationship because the kids have grown up, ending career, maybe not feeling that they've that done everything they want to do. There's a sense of feeling alone, leaving andropause and menopause and the clinical side of that side. There's a thwarted blindness that can happen to men in that group. And then may perceive themselves as a burden. Well, again, my kids are growing up, maybe we have high debts, maybe, what I have to offer me, I'm at the end of my career, or I'm being replaced by the next generation, or whatever, but we can start to think about suicide in a more personable way rather than a clinical way, if I can put it that way. And then one last example is, let's say, a returning soldier from Afghanistan who may or may not have PTSD. Again, what happened? They've left their group that they've been with for several years, so their supported belongingness is happening there. It's also happening at home. Kids are older, things have changed in the neighborhood. They trying to belong to the back in that community takes it some time to transition back. Perceiving themselves as a burden, of course. If I'm dealing with a lot of stress and not able to just jump into regular life, as it is now in 2014 back in small town Nova Scotia after, being deployed, feel like a burden, or I'm, maybe someone does have a clinical issue, so they're feeling that that's adding to the burden. And they've been exposed to death a lot, and so there's a capability of suicide, which matters, which is the third thing. And that's why postvention is so important, is because when people have been exposed to suicide, it greatly increases their capability for it. So you can see there, again, of feeling alone and feeling like a burden, and also being exposed can bring you to suicide attempts. So again, you think about different models, think about different situations. I would say our role as community suicide prevention service providers is to tease these circles apart, is to figure out why, how to increase belongingness and decrease burdensomeness and decrease people's capability for suicide. But that's just me. Next slide, please. So CASP coalition model is a model that we've adopted and developed evidence-based universal approach to addressing suicide in diverse communities is how I would define our coalition model. If you could just click on the link. Yeah.
Mike, which tab would you like me to go to?
Sorry, it's just a little slow on my end. Go to the coalitions.
Okay.
And just click on the coalition model.
Fantastic.
And if you scroll down a little bit, just that first paragraph at the bottom, it says why the coalition model works.
Oh, right here.
Yes.
Okay, there you go.
Click on that. It should pop up. There we go. So I'd encourage you to read this document and understand why we developed the model the way we did. Again, there's a lot of evidence for universal approaches to addressing suicide. But when you try to find a process, there's a wide variety, and we can look around the world at national strategies and see a wide variety of approaches. And we want to be really cautious, I guess, about how we implement something. We don't want to, above all, we don't want to make things worse, but we also want to make sure it's effective and it's moving a community towards being suicide safer. So, so you can click back to that, Meg, and go back to the main screen. I just wanted to show where you can find, and if you just go to the success stories, unless it's gone, which is fine. Yep, success stories. It's meaning for members of our community, and if you scroll through, you can read more on our own time about how working with our individual coalitions is changing and really doing what is supposed to happen, is not only addressing gaps in services, but helping communities understand the issues. And we've got different community plans developed that have been developed by the different coalitions. I've started to host different events, roadside prevention day walks across the province. The Annapolis Valley Coalition is hosting a conference this year, and Cumberland is doing one next year on top of our provincial conference. So you can see that by bringing these core groups together in a community, it really helps to help others get some awareness that this is important for us all to address, even in small town Nova Scotia. So we can go back to the presentation. So this is our basic mandate. It's helping communities come together to build their capacity to address suicide safely and effectively using a population health approach to save lives. And we can skip to the next slide. So our original goal was one coalition per district health authority, and under different provinces have different types of organizations from their health authorities. Others might look at Go County. If you just look at this beautiful map of Nova Scotia, the heartland of Canada, and all that, the trends are in Canada, to be honest with you. But anyway, we have the Cumberland Health Authority. We've got an established coalition. They're right at the north there. We've got one established in Chester East Hants and Pictou County and the Annapolis Valley. We are talking to people in the Capital District, the Capital Health District. But again, this is our largest population area, so there's actually 7 DHAs in this one zone, so it's more complicated. We've got talks with GATA, which is the Guysborough-Antigonish area. That's sort of just the white end next to Cape Breton there. And then the second largest city in Nova Scotia is in the Cape Breton District Health Authority at the Cape Breton. And the beautiful part is mostly rural, and then Sydney is, I don't have a pointer, so I can't show you where it is. So, and I probably should move on anyway. And then we have population-based work that we've done. Back just quickly. We've invited the project, which supports the LGBTQ community across the province, onto our steering committee. We work with First Nations in various ways, helping them advocate for some of their own work that they've accomplished, and as well as each regional coalition involving First Nations and in discussions with the broader community. The heartland of the Mi'kmaq Nation here is in the Cape Breton District Health Authority, Eskasoni, and if you go on YouTube and type in the Resilience, you'll see how the great work they've done to address suicide. And youth. And we've had to change how we work with youth a few times over the years, just as we learn better practices and again, consider safety. We've got reaching out from the Christ Center in British Columbia now being advocated for and offered in all 10 students in Pictou County, and Annapolis Valley is looking at that as well. Instead of working with individual youth, we work with youth groups that are already supporting at-risk youth. So that could be youth at risk at violence, youth with mental issues, LGBTQ youth, and we sort of work together in a coalition of organizations with a number of, like Heartwood as an example of a group that we work with more in Nova Scotia. So, and we find that's better because a lot of these groups are going out, they are sharing personal stories about suicide anyway. So we can help them, educate them, as well as support them at the same time and learn from them and their issues. So it's been a really positive relationship where we've been able to share information rather than just prescribe what youth do. We know that youth will only respond to things that are in partnership, so with adults. So anyway, but that's it about our population coalition. Sorry, you can move to the next slide now. Okay, very basic steps. I mean, we're not the first to form a community group by any means, but these are the suggested starting steps for starting a CASP coalition, and that's to put together your core group. Who would be in that core group? Well, it would be those that have a mandate to prevent suicide in their portfolio already. That might be someone who works in public health. That might be someone who works in district health, and some fashion. People from the hospital and the local community. That would certainly be first responders, police, fire, and ambulance. They deal with suicide on the front lines. It would be other interested stakeholders, teachers, people that lost someone to suicide would certainly be a part of that core group. And however that come together, and then have a community information meeting, just a general meeting, again, talking a bit about safe messaging and suicide and what we hope to accomplish through forming a coalition. We get those people to also invite other members, like who's missing, who needs to be at the table, is there a faith leader in the community that's really active in this area or whomever. And then the first meeting is planned and held. It's really important to keep the momentum going so that by the time you plan to hold your first meeting, you're not dealing with a whole different set of people. So that's a lesson that we've learned. So these things have to happen in succession fairly systematically. Follow up on the first meeting, invite people to come to the Safe Talk session that's going to be arranged. We try to provide a subsidized Safe Talk session to everyone who's come together at this point. Just really to put us on the same page, Safe Talk is a program of living works education. It's a 3-hour course. It gives people the basics of how to be suicide alert and to destigmatize suicide and make sure that we're all on the same page. And we also put an extra emphasis on safety. From there, we organize the toolkit orientation training. So that's when we bring that group together. We use different models from the art of hosting, like a World Cafe model, to help the group decide what are the priorities in the community, what's important, what are the gaps, and we have a systematic process we go through. There's other models to organize out there that people can look at. But by going through a systematic process, then we write up a report. Dave, who's watching right now, is working on a report for a group that just had their forum, and that report is a guidepost for that community. It has the information that is known to be missing. What are the gaps in services? What do they want more of? How are they going to come together in the future? It's the beginning. And that's about it. I'll say about the toolkit orientation training. We don't have the toolkit widely available yet, but certainly if you contact us, and we can talk about more about how we can scale up the toolkit at the end. Next slide, please. Okay, I'll just touch on this before we run out of time. And we're talking about, the positive actions we can take in community suicide prevention, but it's really important to take that in the context of having a shifting landscape. And that's where we really come to understand resiliency better. Next slide, please. Because we traces of resiliency in the West. It's talked about all the time. And again, like I mentioned earlier, resiliency research wasn't as much on our radar as it is now. And I have to thank the Resiliency Research Center. You can go to resiliencyresearch.org or lindaliebenberg.com to find out more information about partners at the Resiliency Research Project.
Mike, sorry to cut you off, but a few of our listeners are wondering if you can just speak up a little bit, please.
Yeah, I think I pulled the foot from my mouth. So that, I certainly will. I was just talking about the Resiliency Research Center and how you can learn more about their work. I'm running on time, but as Meg showing you that, I do want to share with you Nikki's story, because this is impactful at our Canadian Mental Health Association Women in Wellness event the other night. They work all around the world about resiliency, and this is Linda Liebenberg. This is a case study of hers. Nikki was a 15-year-old mom in the slums of West South Africa. She had 2 infant children, aged 2 and 4, and no natural supports around her, no husband or parents to support her. So, 15-year-old mom with 2 infant kids, and they discussed with her as a part of this case study, what her options, and what her options were. She'd live on the street, and there's the lack of food and the risk to her children that came through that. She could go to the formal system, but the formal system there would mean that she would lose her children and lose access to them most likely, as they would maybe go into adoption or whatever. So she didn't see that as an option. And lastly, where she up is she could live with a couple of men, and there, obviously there was other, she had to give up. She was, there for them, I'll put it that way. But it gave shelter to her children. It gave food. It allowed her to stay in her community where she had other natural community supports, other moms of other kids around. So she was her best option. And we in the West would say, well, it's something we go in, we have non-government organizations, and we build scaffolding around Nikki so that she can keep her kids and that she can have a safe apartment, that she can have, regular access to food and medical care without putting herself at risk. And yet, West, and the point I want to make is that we have the scaffolding for our children already. We've built it. We've put up so much that perhaps we've lost something in the process. So as we're looking forward to new technologies and new research and education about, how we can prevent suicide, it's really important to step back and look, because our resiliency rates here in the West, where we have all these things, are not dissimilar to the resiliency rates for people like Nikki and her community. So what does that tell us? I think it tells us a lot. About risks that our kids are in with that scaffolding. So I'd encourage you to look at the Children and Youth in Challenging Contexts text network when you have time for a little bit more information as well, other than what you just saw on your screen. But it was on BBC the other night talking about the epidemic of loneliness in our society, and we all sort of know this is going on, and that 50 happy birthdays on Facebook is maybe less important than one happy birthday from a friend in person. I don't know. That's how I feel. But connections is really bad for us, and we really don't have our heads around that. And that's just as you point out, when we look at how we support those that are grieving. Those that are grieving from suicide loss deal with so much different stigma than those that are just grieving. But we all are losing sight on how to grieve, as a community. And at the Canadian Mental Health Association Nova Scotia Division, we have a project called the SEEK Project, based around social and emotional learning, and it's putting in curriculum some of these skills that aren't doing for our children anymore. How do they handle anger and anxiety and loneliness? And I have to give credit to our executive director, Gail Gardner, for pointing out to me that, the work we do at SEEK is to kind of prevent the work we have to do at CASP. And, I think that's really important. And so programs that promote resiliency with younger children are certainly one pathway that we can look at to start to deal with the crisis of resiliency, as well as some other things. Next slide, please. We're doing in Nova Scotia right now. We have renewed our focus. We are promoting resiliency and increased networking among all stakeholders. Of course, we have to ask the question, is resiliency a key factor in preventing suicide? We felt intrinsically it was, but we've come to the Nova Scotia Health Research Foundation to do research just on this, the Community Suicide Prevention and Resiliency Research Project, aptly named, and that is still in development. So I didn't really quote that accurately. Someday, I think in August, it will say Sweeney et al. 2014, but that's not what it says now. It's still in press. So, but when that research is available, I hope to have the opportunity to share it widely and to bring the researchers forward to talk about it themselves. Next slide. So, again, just an interest of stepping back a little bit, and mentioned earlier about how there's so many resources or funding flowing into maybe more clinical settings where us that work in the community are really working to just hobble there sometimes programming because we're resourced. So what can we accomplish? I think community coalitions can help build resiliency. I'm hoping we can prove that. Do we just keep investing in developing newer and better gatekeeper trainings? Can we develop the penultimate gatekeeper training that's going to keep everybody safe from suicide? No. Gatekeeper training is important, but it's one aspect of suicide prevention, and I think there's a lot more aspects. Suicide, we know, is multidisciplinary. It's not just psychology. It involves epidemiology. It involves anthropology, and I could go on, but it's multidisciplinary. So to funnel everything through one lens just doesn't make sense. So we have some big questions, and I'm sure they're being asked all over the place. Where do we invest in suicide prevention? I would like to see more investment in community suicide prevention, and I'm sure there's many colleagues out there that would agree. And we also need to invest in our communities. Do we really value as a community? Like, again, what Linda Liebenberg pointed out was so correct that, we're more concerned about the death of a celebrity than what might be happening around the corner from us, that we have become really insulated even though we live in communities. And my wife works with new immigrants, and some of them are just amazed at how hard it is to meet anybody from here because we're so isolated. We're just so cut off. What's going on? How do we restore our ability to cope as a community? We're just getting our heads around now suicide prevention. So how can we expand on that? How can we grow and all come together under the same umbrella and not be in a case where we're fighting for dollars, but we're all building on each other's work, and pulling in new resources like what we have from the Resiliency Research Center. Do we look there? We can look to other areas that have invented, companion robots to help the lonely or to sit with elderly. I think it was the piece I saw. There's lots of different places. Do we build better apps? Do we try to find out ways to care more and really become communities that address suicide together? And that's all I have for you today. You can see some of the references there. And if you have any questions, if you want to open
thank you so much, Mike. That was a great presentation. We have about 10 to 15 minutes for question and answers now. So we had a number of questions come in while you were speaking, and I really appreciated your statement about how we need to think about suicide from this personal perspective in addition to the clinical perspective. Last month we had a really informative webinar on trauma-informed care, and so I see there's a really great crossover in how trauma-informed care is informing the personal perspective as well. I'll start with the first question we received, and it's related to services. Actually, two questions related to services. And the first is wondering if there are any organizations with staff who visit lonely people in their homes within their communities.
Mandate to do that, not that I'm aware of. I think people look forward to their VN nurse or that sort of thing coming to visit, but it's a good thought. Especially, consider the really tough communities, the little person in the wintertime and that sort of thing. Yeah, good. Yeah, I'm not aware of any programs, though, I'm afraid.
Okay. No worries. As we become aware of any of these services, we will include them on our website and in collaborative spaces. The second service-related question that we have is if you're aware of any specialized information or resources relating to suicide prevention, intervention, or postvention for people with developmental disabilities.
Oh, that is such a good question. I am aware of some work by Michael Fitzgerald, I believe it is, around people with autism. People with autism, I think, are known to be, according to work anyway, 7 times more likely to die by suicide. Beyond that group, I'm not aware of any sort of larger look at people with developmental disabilities as a whole. I think you'd probably find different risk factors, again, for different specific disabilities, like, Down syndrome versus autism versus, whatever. So, again, sorry, I point you right to something that addresses that. And I'll be honest, I think it's really an area that is not looked at very much and hasn't been looked at very much. To read the risk factors of suicide in someone with developmental disabilities can be quite difficult, especially with other mental illness. Yeah.
Well, I see that some of our participants are responding to those questions in the chat function. So it looks there are services available for those, both those who are in their homes and with developmental disabilities. So that's great. One of the other questions that we had. Yeah, one of the other questions we had about restricting means was when you were talking about the modifications to the bridges, and we're wondering if the overall suicide rate dropped, or if the suicides moved to another location or other means.
That's what I guess I'm wondering. Valid question. Good question. Some say, well, the statistical data is not in. Nova Scotia is of such a size that we really need to wait a period of time before we do research on, or otherwise we're going to be identifying people who have recently died by suicide and impacting families. So the latest statistical report only goes up to 2004, I think, maybe 2007, but it doesn't cover the period of time since we've had the erected. And some would argue that, it drives it sort of more underground. What it certainly does accomplish is it place in a community that's known to be the place people go to die by suicide is dangerous. Because someone can, again, because they've been drinking alcohol or they're impulsive sins or for whatever, it's just too easy to die by suicide that way if someone is in a desperate state. So, and it's not to say that the bridge still doesn't encounter people with thoughts of suicide on the bridge. It's just that events that impulsive move happening. So off that, I believe that Niagara Falls, for instance, doesn't even have barriers. So and it's one of the most popular places to die by suicide in the world. So the jury is still out on whether it's had an impact on suicide rates, but I will say it has an impact on just the culture around suicide behavior. Because again, that bridge sort of, and the Golden Gate Bridge and other places become sort of notorious places. And I think if we can restrict suicide there, we're more likely to help people. And again, that it's not in isolation. Restricting other means of access to suicide would go right along with that. But our comment, do we know definitively that bridge barriers reduce the rates of suicide? Some would argue no, that it just sort of drives it to places where they're less likely to get support. I would say that anytime we can stop someone from making an impulsive decision, then it's a good thing. So,
absolutely.
I
think one of the last questions that we had that came through was if there's any specific resources or recommendations for school boards that you're aware of.
I was going to touch on this a little bit earlier. One of the trends I've really noticed is what you call school-wide suicide prevention approaches. Okay, so and I've advocated for this in Nova Scotia that rather than have different resources and programs to have or have a school-wide anti-bullying program, to have a school-wide suicide prevention program. Because I think all school-wide suicide prevention programs, all good ones, will address bullying naturally as they go. So I believe Manitoba has a provincial program. They're working with Sources of Strength, I'm told. Quebec has a provincial program for the French School Board, which has measured some great results in reducing suicide. On our website, you can find some links to toolkits for schools for dealing with sort of after a suicide, and we've done a lot of work with the Department of Education around preventing unsafe speakers from coming in and talking about suicide, for making sure that there's some vetting process for when someone's going to talk about suicide, and it's not in large assemblies, and that the right support's around, and there's practices that need to be followed by schools if they're going to address suicide. Again, we use reaching out. You can find the Crisis Center in BC and order a copy from them. It's a 1-hour VO workshop that really just touches on the basics of being aware of how to friend and ask the question so you can get them the help they need. So, that's about all I have to say to that. But, yeah, just go through our website and you'll see links to other organizations. And again, programs like Sources of Strength, and I'm sorry I've lost the name of the French program, but I did see a workshop on it, and it was very impressive. So I think having comprehensive strategies for schools is the trend that you're going to keep seeing, rather than just specific resources. So, yeah.
Great. Well, thank you so much, Mike. As you can all see, his contact information is visible on your screen, as well as my own. We would encourage all of you to continue this conversation on social media using the hashtag suicide prevention, and as well as joining the Commission's collaborative spaces. On May 21st at 1 p.m., the Knowledge Exchange Center is hosting a short webinar on the work that we do here at the Commission. So if you're interested in tuning in, please visit our website. But Mike, I would just like to thank you again for joining us today. A copy of his slides in both French and English, as well as the recording, will be available on our website within the coming week. And if you have any questions for either Mike or myself, please email them to us at your leisure. So thank you so much, and we will see you on Tuesday, June 10th for our next webinar on peer support and suicide prevention. Have a good day.
Thank you.